Hello, I'm Penina from Circle Care Services, and welcome to My BCBA Life. Circle Care Services is an ABA therapy agency, and we're all about giving BCBAs the support and community you're looking for. With this podcast, you're not on your own anymore. You're part of a BCBA community committed to making this world a better place to BCBA. Once this episode is complete, you'll be able to obtain a free CEU certificate for the clinical topic discussed. You'll need to confirm your attendance by taking note of the 3 surprise words I will drop throughout this episode. There is a link in the show notes below of a form that will ask you for your information and the surprise words that we need to generate your CEU certificate. Thank you, and let's get started. Welcome, Dena Kelly, to My BCBA Life. I am super excited you are here because I know that you have so much value to share with all the BCBAs. So if you could please just introduce yourself and tell everyone who you are and what you do.
Sure. Thank you, Penina, for having me on today. My name is Dena Kelly. I am a licensed professional counselor and a board-certified behavior analyst, and I have been specifically doing feeding specialty for just about 15 years at this point. Currently in private practice, but have worked in an intensive feeding clinic as well as in an ABA center developing a feeding program for an ABA clinic.
And when you say you do you do other programs besides for feeding, or do you really just work on the feeding aspect?
So now primarily it's just feeding. I do have, throughout my years, especially with having an LPC background, I do have that interest in direct counseling as well. And so throughout my professional career, I have actually been working a lot with the adult autism population. So usually 20 and older that are struggling with things, a lot of the same things that the kids are struggling with, but now they're adults and there's not as many services available for them. And so I had, a big focus on that. I was doing a lot of adult diagnostic testing. Currently now I do still see a few adult individuals with autism, but my primary focus is, and has been for years, is direct feeding therapy.
That's great. And from my understanding, when implementing the feeding therapy, you are using BCBA behavioral programs, which we'll talk about. So let's just go into the background of feeding issues, because obviously feeding issues are not exclusive to children with autism. All kids can deal with that. But from my understanding, children with autism can be more prone to it. So could you just go into why children with autism would have more sensitivities towards feeding and why they would have more difficulties when it comes to skills like eating?
Yeah, absolutely. Well, first off, you're absolutely right in the sense that it's not just children with autism that have feeding challenges. That was one of the reasons why I started my own clinic or my own practice, was so that I could work with a variety of children that were struggling with these issues, regardless of what diagnosis that they had. So some of the children will have ADHD, some have anxiety or OCD. And some have not been necessarily diagnosed with anything, but feeding has just been an area of struggle for them. So it certainly can happen to a larger population as well. But there is absolutely, you're right, a higher prevalence rate for children with autism to be struggling with feeding challenges. And really, the primary answer for that is typically when you think about what qualifies a child for an autism diagnosis, you're looking at things like rigidity, insistence on sameness, struggling with changes in routine, or really requiring a routine to thrive and know what's coming throughout the day. Higher sensitivity to certain textures, right? All of those things can impact behavior. And what happens in just regular life, right, is a lot of times we eat on the go. And so we're kind of crazy. Maybe we're grabbing something from the drive-through, we need to eat in the car. We're eating while the older kids at basketball practice in the middle of the gym floor, right? And so those environments can change, the food can change, all of those things can change. And so that can be a really big challenge for children with autism. It also, food has smells, right? They all have different smells. They all have different textures. They can be presented in a bunch of different ways, right? So when you think about a strawberry, right, you could have a whole strawberry, you could have it cut into slices, you could have it cut into chunks, you could have it pureed into a smoothie, right? There's a lot of different ways in which that same thing can be presented. And that can send a lot of kids, but especially ones with an autism diagnosis, down a spiral. The other thing that I see sometimes happen is that oftentimes when a family's dealing with getting a new diagnosis for their child with autism, it is really overwhelming. The child's usually about 2 to 3 years old in most of, those common younger cases. And the parents are in a whirlwind. What do I do? Where do I go? What services do I need to get? What services should I avoid? And sometimes the food refusal just falls to the wayside because now they're working on establishing their ABA clinic, their OT therapist, their speech therapist, all of those other things. And what happens in the meantime is this child that was developing some food refusal has now gone another 1 to maybe 3 years with a continued history of that food refusal. And so then by the time everything has kind of settled, the parents feel comfortable, they have a strong case management, they have all of their systems in place, and they say, now we want to work on feeding, is that now that child might be 5, 6, 7 years old and has been having food refusal and is even more set in their ways of what they want to eat and what they don't want to eat, which can lead to more challenges when it comes to looking at that intervention.
My first surprise word is moods. That's a very good point. Everything you said before you even hit on that point of why a child with autism is prone to it hit on the spot. And because it's just general things, the rigidity, the sensitivity, the sensory aspect, there are so many things, like you said, that are going to be affected from it, not just eating. But eating, of course, will be, because eating encompasses all of that. With the examples you mentioned, it's very clear to see how. And then also when you talked about the age, that's also crucial. And as you said, if it's not taken care of right away, they're going to be more set in their ways, and they think it's okay because it wasn't dealt with. So obviously, I think a big takeaway from all that is that, especially if they're going to go, because usually ABA is going to be the first thing recommended. Okay, get ABA services. And as a BCBA, you can focus on the feeding part right away. So if you could just share with us why the eating, and I think most of us can answer it in our own heads, but it's nice to hear it from you who's an expert in this. Why is the eating aspect crucial to deal with, especially if the child is eating 1 or 2 things? So is it still so crucial if they're getting something?
Yeah. Okay. So two big questions you threw out there right there. But yes, absolutely. So first of all, right, your question on why is it important to deal with the feeding issues? And the issue is because it impacts every other area of their life, of our life, everybody's life, food, right? As adults, I think we've all joked at some point, sent a meme to somebody else, right, or a friend, at this concept of hangriness. We've all had that feeling of, what happens when you go too long without eating, right? You become the devil, or you become like this terror person. And we can joke about it and say, right, get me my tacos now, or get me, whatever those things are. The same thing's happening to these kiddos, but they can't express it in the same way. And so what often happens with them is that it comes out as tantrums, sleep challenges, and toileting issues, which end up being the other things that people will go to look at and address. But my first question ultimately and usually is, what does their food intake look like? Because when we think about a young kiddo, 2 or 3 years old, going into an ABA clinic, I would argue that a good amount of those children's treatment plans are going to include a behavior reduction plan for tantruming, right? And a lot of time, not always, but a lot of time, a big underlying factor to those tantrums are their lack of food intake. And so when we can address that food intake challenge is often on or their own, those tantrums will decrease. And so, for me personally, it was really cool because initially for years where I got a lot of my feeding training was in a very isolated feeding clinic, right? Children would come for their feeding services and then they would leave and go do all of the other things that they needed to do. Then when I actually got to work inside an ABA clinic and I was working directly with those children and the BCBAs and RBTs that were in that clinic, I was able to actually see firsthand, okay, here's this child, he's coming in. I could hear him down the hallway from my office, crying and having tantrums in the hallway. He comes into my program, we work through food refusal, and now it's just such a different child. I would have the BCBA popping in and going, he's flying through programming now. And I would say, awesome, because he feels good, right? He feels regulated. He feels satisfied, satiated. And it allows when you're not hungry, it allows you to be able to focus and concentrate on other things. And we've all had those experiences. You're sitting at your office desk and you're working, and all of a sudden you realize you're not staying on task anymore, or you're finding yourself, frumping in the chair or getting easily distracted with other things. And then you go, oh my gosh, it's noon. I need to eat lunch, right? And that's the same sort of thing that's happening with these kiddos. And we just don't look at it in the same way.
It's true. I think also a big point, what you're saying is that tantruming often, not always, but can come from lack of eating. And I think when a BCBA takes that ABC data, we're not just looking at what happened before. We also want to look at the time of day, and based on that, you could also get a good feel is the child eating well before? How long has time passed since their last meal or since their last snack? That's also a key point. I know we once were talking about it with our clinical director and BCBAs when she was bringing up this point, she said there was a child in school who would come to school and would not be okay it was just tantruming, acting out, and they were trying to figure out, pull the ABC data, and they realized that they said, you know what, let's see what happened before. Did the child eat a good breakfast? And the answer was no, the child was not getting a good breakfast at home. And it was an easy fix. They gave the child breakfast in school and the child was great. So even if they don't want to always just say what's feeding, it's very important in the ABC data to get like a full comprehensive idea of what's happening, not just situational, but also time and setting and what's missing.
Yeah. And the reality too is that it impacts all these other things that also can impact that behavior, right? So if we're not eating well, we're not sleeping well, right? If we're not sleeping well, we're also not functioning well. And if we're not eating well, we're often going to be dealing more often with constipation type issues. And everybody knows that when you are constipated, you don't feel so good and you don't feel like, running down the hallway to do an activity or focusing on, a hard task to complete. And so they really all, correlate together. And that feeding component really impacts all of their areas of life.
So I think you answered the question why it's so important and why BCBAs should probably check that first, and if they are dealing with a young child who does have feeding issues, that is priority and it should be looked at as priority to work on. And I think I asked you if it's so important to work on it if the child is eating one or two things. I know my client, they're not tantruming because they eat their favorite yogurt and they're good, even if they're eating it for breakfast, lunch, and dinner. Should it still be a priority as a BCBA to work on introducing more foods?
Yes. So perhaps not first priority then if there's other things going on. If the child is consistently satiated throughout the day, feeling good, and the family is not overly stressed, then potentially it doesn't have to be the first. However, absolutely, if you're talking, if a child is living on, let's say, Greek yogurt and strawberries, right? We could say, oh, there's worse things that they could be eating, and let's be happy with where they're at. What we need to be thinking about is all of the other parts that food does with our lives, right? So it becomes such a social event. So we think about part of what we do, especially with the little kids and early intervention programs, right, is you're getting them ready for a school environment. What happens in school? You have lunch, you have snack time, you're with your peers. You need to be able to independently eat some different things. You might go to a birthday party, and usually what's at a birthday party? Pizza, chicken nuggets, birthday cake, right? I've had some kids where we've actually worked on introducing a cupcake, which seems so silly in a feeding therapy program where you're talking about fruits and vegetables and meats. But to me, the social component is just as important as anything else. And so if that child wants to be able to be part of the birthday experience, I want to be able to get them to be able to be part of that birthday experience. Different holidays, going out to restaurants. There's so many parts of eating that aren't even just about your body, but then become about that social component as well. And so there's definitely a lot of things to consider. I really look at for overall functioning and well-being and flexibility across the board is that you want to have a few different things within each food group. But even within that, you want to have some flexibility in how those foods are presented. So in your example with the yogurt, if that kiddo is great at eating yogurt and does really awesome, and all of a sudden that yogurt company goes out of business, or they completely change their label, or they adjust their recipe, or they do something, and now that child is not interested in eating that yogurt anymore. Well, now they're stuck, right? Now they have nothing. And so not only do I want to be able to work on awesome that he's eating yogurt, let's practice a few different brands, flavors, presentations of that yogurt, and then be able to also expand out to some other food groups and varieties of food.
You just gave so much good information. I love what you said specifically about the social, because when we think food, we're just thinking shouldn't be hungry. I'm saying me, I talk for myself. I'm thinking we don't want the child to be hungry. We want the child to be able to be functional. And then you bring in the social setting, and we all know that we work so hard that every child, specifically the children with autism, the social doesn't come so natural to them. When you bring in the social setting with food is also a very easy way to socialize. And if they're also missing that, then it just puts them on such a lower grade for social. If they can't hang out with their friends and they don't have to talk, but just eat the popcorn with them, then that in itself is really being part of the group. And if you feel like you can't, then they feel like a loner. Or like you said, at a lunch table. Also, I would assume if a person brings the same food to school every day. I think this happened with my nephew. He always brought pizza to school, and then he was being made fun of, like, oh, that's all you eat? And then he needed to bring something else. So he was able to eat something else easily, but if a child can't, then that's an issue. I would assume if it bothered them so much, they just might opt out of lunch. So the social is such a key point, and I appreciate that you brought that into the picture. My second surprise word is table.
Absolutely. And that happens across the board. Even, the typical response, right, is families will say like, oh, my child only eats chicken nuggets, right? That usually is like the stereotypical picky eater kid. Most schools, you can't heat up that lunch, or a camp, you're sending your child to a camp in the summer. You can't send a hot lunch, and you don't have that opportunity to warm food up. And so then your child's stuck either eating cold chicken nuggets or not eating lunch, and having that difficulty functioning throughout the day. And so yes, absolutely, you want to make sure that they have that variety so that they can engage in those social events.
Amazing. Okay, so now that we fully understand the importance of it, I would love if a BCBA comes into this situation where the child is having difficulty with eating or is only doing the same foods. what should be the BCBA's first step when it comes to that? What should their first response be? Walk us through that, please.
Yeah. So with any child that's potentially having significant food refusal, you want to make sure that you're ruling out any medical barriers. And sometimes they can be correlated, right? We were talking about like the constipation. If you're really constipated, you're not going to feel like eating. And so we have to work on how can we effectively clear out that constipation before we could actually address eating, because you're not going to have any motivation or interest to want to eat if you're not feeling good. But on top of that, there's other medical issues. There's other GI issues. There's potential for food allergies. There's some kids are born with different mouth deformities. So they might have a much higher palate, or they may have some different formation of their teeth or gums or their mouth that can make it really challenging for them to eat, or potentially actually dangerous for certain textures, depending on how they're doing. There's also other types of disorders that children can have that can impact their ability to swallow certain textures. So all those are the types of things, before we would look at treating from a behavioral approach for feeding, is that we want to make sure that those medical components are ruled out and that the child is safe to be introduced to new foods, and that the refusal is rooted more in that history of avoidance of those foods rather than an underlying medical concern.
And who rules that out? That would be everything you mentioned. A pediatrician could get involved and look at the mouth and give all that, or does it need to be a specialty?
So, well, a pediatrician would obviously be the first step for sure, but they may refer to GI that may need to look at, if they're having stomach issues, they may need a swallow study. Sometimes speech and language pathologists can look at and assess some oral motor skills and some mouth deformities that may impact eating. So the pediatrician would be the first step as far as figuring out the referrals to the appropriate medical professionals to make sure that the child
Okay, and then
clear.
besides for medical, if let's say we clear that out, it's not a medical issue, this child is safe to eat and to be introduced to other foods, what other issues are we looking at that could perhaps lean into this feeding issue?
Yeah, so next would be family dynamics for sure. Because what we absolutely know, even if you're working with a child in a clinic setting, is that they need to be able to eat with the family. And so one of the biggest things I require for anybody doing, my programming is, or even when I train my BCBAs to be able to do it for their families, is that the family has to be committed and the family has to be involved. And so when you're having a family that is consistently canceling their parent sessions, the child's showing up late, you're having, inconsistent data and results in what you're doing, that's not going to lend itself well to feeding. And one of the biggest reasons for that is the first step in what I look at is establishing a good eating routine. And so, like we talked about earlier, where a lot of families are on the go and they're rushing and day life is crazy, and evening life is crazy, is that in order to work through a child that has food refusal, you have to be committed to be able to say, how am I going to make adjustments in that environment to be able to make sure that they are comfortable and that they understand the expectations and the routine of what's going to happen at mealtime. And so that family dynamic, getting the buy-in from the parents is not always easy. From some of them, it's amazing, right? And they say, you tell me what I need to do and I will do it no matter what it takes. And there are other ones that will say, yeah, no problem. And, don't actually show up or do the things that need to be done. Right. And so we've all experienced, I'm sure, a variety of those different types of family dynamics. And so it's really important to make sure that you have buy-in from the family, that you understand what the family's goals are for treatment, and if the child's old enough, what the child's goals are for treatment. Obviously, most 2-year-olds, you're not going to sit down and have a conversation on, how many new foods would you like to add to your repertoire? They're not going to be able to have those conversations with you. Those are going to be more parent focused on what are other foods that your other kids in your house are eating? What are things that you're eating in your house that you'd want them to be able to eat? That's one of the driving points when I talk with families, when we talk about food, is that feeding therapy is not meant to be, I'm going to turn my child into the fanciest, most sophisticated eater, and they will be sitting there and eating, fancy fish with Brussels sprouts and asparagus and all of those things. I want that child to be able to comfortably eat the family dinners that the other kids are eating in the household, things that they're going to, again, have at the birthday parties and all of that, so that they are, able to be a part of those experiences. But if you are working with an older kid, you absolutely can get them involved in the process. You want to be able to have them involved in what are some foods that you might be willing to give a try to, and what are some foods that are an absolute no-go for you that you want no interest in trying? And that really leads to, for me, this point of thinking about when children have feeding challenges, especially if they really qualify for a feeding disorder diagnosis, more often than not, they are not intrinsically motivated or interested in eating, right? For me, I'm thinking about food pretty much from the time I wake up till the time I go to sleep. Every meal, when I'm eating it, I'm thinking about the next meal. Even if I'm full, if somebody brings out dessert, I'm here for it. I'm probably going to have a piece of cake, right? I am internally motivated and interested in eating. It gives me pleasure. It gives me joy. And I, really benefit from it. I don't need people around me clapping their hands. I don't need to earn anything for it. My earning is the flavor that I get while I'm enjoying.
I think
that
most
food,
of us could
right?
relate to that.
So, but these children, absolutely, right? But these children with feeding disorders don't have that same internal drive or interest in eating. And so typically you have to bring in external motivators to be able to enhance that interest, right? Because at the end of the day, we have to eat. We have to consume food in order to survive. It's the same as brushing our teeth, getting dressed, getting in the car, right? All going to school, all of the daily living type activities that we do that oftentimes children aren't always 100% on board with. You sometimes have to motivate them to do those things, right? You finish brushing your teeth and you can, jump rope yourself to the car. You brush your teeth before bed and I will have 3 books waiting for you in your bedroom, right? There's different things that you're going to say, clean up your toys and we can go to the playground, right? They're not interested in cleaning up their toys, but now they're going to because they want to go to the playground. So when we think about food and eating in a similar way, we can look at that same external motivators for our children for eating, is what are some things that we can motivate them with that they are interested in and want to do once they complete their goal of eating, similar to cleaning up toys, brushing their teeth, any of those sorts of other types of daily living skills. Now, obviously with eating, there's a lot of foods and a lot of textures and a lot of flavors and a lot of things. And we know, just as all of us, nobody loves every single food that they eat. I don't think I found any person that says, there's nothing you can give me that I won't eat. I feel like there's something for everyone, right? So everybody has a preference. And so with kids, when we're doing feeding therapy, we have to be cognizant of that, in the sense that they're not necessarily going to love everything. But what I look at from a feeding therapy perspective is we have to expose ourselves to those foods. We have to try those foods, consume those foods over a few different times and compare them to other foods to be able to really know, do I not like that food? Or had I just never had that food and I thought it was scary, but actually it's pretty good. And being able to, move forward and enjoy eating. And so when we have an older kid, I like to get them as involved in that process as I possibly can. With the younger kids, we're looking much more at their behavior based on the food presentations to be able to assess that difference.
Interesting. And I think for BCBAs and even the ABA therapists on the ground, when it comes to food, either they think it's just, not for me, maybe this is more a medical thing, or they could just be like scared. It's like, it's like you said, it's crucial, it's critical for a child's survival. So maybe it's above me, maybe I can't deal with it. So what do you recommend to them to how could they approach it feeling good about it, like they're capable? Obviously, if it's not a severe case where we need a specialist in the picture, but if it's where just the child is having some difficulties and they for sure should try it themselves in the beginning if it's not if the child's eating a little bit. So how could they approach it?
Yeah, so absolutely. I mean, obviously, like you said, the disclaimer of there's certain situations where the child's food refusal is severe and past the point of some, more outpatient interventions and really requires more of that intensive treatment program by a feeding professional. But a lot of feeding interventions are ABA techniques. And so, that's what's always so enjoyable for me. And part of what I do is a lot of training for BCBAs and clinics to be able to have a bigger understanding of food refusal and how can they apply that to the kiddos that they're working with in their programming, and how can they just weave that into the treatment program that they have to be able to have more success with those children. And so when I do these programs, these BCBAs go, I do that, but like not in feeding, right? And so I always say yes, but exactly. But we can, if we start looking at feeding as a daily living skill, as a function of activity that has to occur in order for that child to function effectively, and we don't look at it with all of this extra emotion that seems to be attached to food, right? Because like we were talking about earlier, everybody has preferences. And so we all bring those preferences to the food table. And so, if you have a child that doesn't want to eat cucumbers and you don't like cucumbers, you can go, oh, well, I get it. I mean, I don't like cucumbers, so why would I make that child eat cucumbers? Because a lot of other people like cucumbers, and maybe this child, if they were exposed to them, could actually like them. We also have a lot of fear and angst that comes with, if I make food a forefront of treatment, is that it's going to cause bigger issues and it's going to potentially lead to an eating disorder, or it's going to potentially lead to higher food refusal. And when done appropriately and effectively, and especially under the guidance of a feeding specialist, there is no research to suggest that that actually happens. And, over the past 15 years that I've been doing this, I still check in intermittently throughout the years with families that I have worked with in years past, and they have nothing but great and continued great things to say. So we're not seeing that in professional life. I'm not seeing that in the research to be able to show that that there's any correlation there. And so if we can take the emotional component and the fear out of it, there are things that we can do. As BCBAs in a clinic, there's certainly things you can look at, right? And again, it's going to be child specific, age specific, environment specific. So these are very generalized in what I'm going to talk about. And you'd have to think about how they would impact or apply to your specific kiddo. But first and foremost, and I already mentioned it, is the mealtime routine. And so setting a set schedule for when a child eats. And one of the first things that families do when they have a really picky eater, a restrictive eater, is that at any point that that child shows interest in food, no matter what that food is, they say, here you go, have all of this, right? But so what happens is that then we get into a kiddo that falls into grazing on snack foods, right? So especially whether you're at home or you're in the clinic and thinking about it from a programming perspective, you're an RBT that's with this child for 6 hours, and every 10 minutes, you're either running back to grab another handful of Pirate's Booty or Doritos, or you find yourself walking with it in your pocket to constantly be able to hand to that child whenever they're requesting those foods, right? Happens to us all the time. We get into those ruts. The problem is that, one, it doesn't allow us then a good opportunity to be able to sit down to introduce those new foods because they're not used to coming to a table and sitting and eating. And two, if we're grazing throughout the day, we never allow our bodies the opportunity to feel hunger, to process and digest the food that we ate and be able to feel hunger, right? So, when we eat popcorn, sit and just pop popcorn in throughout the day, you don't want dinner because you feel just funky and full. And so inadvertently, that's what's happening in a lot of clinic and home settings with these kiddos, is they are not having those structured meal times and snack times. And so the first thing I look at before you even look at new food introduction is taking whatever foods that they're already eating, but put them into breakfast snack, lunch snack, dinner snack, depending on when that kid's eating, and have break times in between there where we're going to be doing other activities that aren't food, right? And so in the beginning, they're going to be requesting that food pretty frequently because that's what they're used to getting. So it takes a lot of redirection and programming to be able to divert that so that you can get through that hour or two block of time before we're going back again. But then when we go back to eat, we're going to go back. We're going to sit at a good chair. We're going to sit at the table. We're going to, have the food, the snack that's in front of us. And then we leave. And when we leave the table, we're leaving like the food until that next time that we're coming back to eat. And so before we even look at any additional food introduction, we have to establish the consistency of what mealtime looks like and how do I access that food. Again, as the child continues to grow and they go through therapies and different things, you get more flexible in that. And I don't think you have to stay in that level of rigidity forever. But without establishing a good routine and a good plan, it doesn't lend itself to being able to do any further introduction or intervention. And I've had some kids that, go ahead. I was just going to say, I've had some kids that have come to me for treatment, and just by doing that, they were more open to just trying some new foods, and we started to be able to get some great snowballs. And so some kids really just need that structure and that routine and that visual schedule. Here comes snack time. Okay, here comes dinner time. And they know that that is what they are expected to do during that interval of time.
My third surprise word is soft. That's great. I think this goes hand in hand with the thing how you said it's so important to work with the family, because it's impossible for a therapist to be there breakfast, lunch, dinner with the child in the family home. And I think another very important factor to bring up to the parents is not just the goals, but if a family isn't having that routine of breakfast, lunch, dinner, then really asking them why are they having a hard time with that and really helping the family set that routine. It's good for everybody, not just for that child. It's really good to have a routine of breakfast, lunch, dinner for no matter the age and for every family dynamic. So when working on goal setting, to really spend time with the family saying, okay, so if you aren't doing this, why, and how could we adjust it, obviously in a way that works for your family so that it could actually take place. And I think parents will also, they'll deliver if this is all good things that probably most parents want. And if they aren't able to deliver on it, it must be for a reason. So really working with the parents to get to that point of what are the issues? Why can't you do this? Let's work together. Forget about the food, but let's just set routine, kind of, because you said that's a really key factor to having a child eat. Um, so working with the parents in that sense also of let's make it work together so that you don't have to be there every mealtime because it's just impractical.
Absolutely. Yep. And that's something, again, that you would do before you'd even do any additional food introduction. And so it's something, it's almost the easiest thing as much as it's the hardest thing. It in essence should be the easiest thing to be able to brainstorm and come up with ways in which you can make that a priority and setting that routine to set the environment up for success for a future food introduction.
Yes, and I'm curious, once we have that set up and the child is in a routine, what are practical ways to deal with common feeding issues? I would like if you could give like a few of the like biggest issues that you see and how you respond to that.
Yeah, so again, it's going to depend on what the issues are with that child, right? So we could have the variety issue, we could have a volume issue, or we could have an independence issue, and we could have a chewing issue, right? So there's a lot of different components that could be there as to why that child is refusing foods. And so you want to make sure that you're establishing with the parents goals and looking at the hierarchy of those goals and what we're going to treat. When we're looking at a variety issue, one of the first things that I will do is look at the foods that they're already eating and what is a small or slight change that I can make to that food to be able to challenge that kiddo slightly out of their comfort zone while still within the realm of something they're somewhat familiar with, right? So we talked about, the yogurt that a child likes. So maybe changing either just the flavor of the yogurt or the brand of the yogurt and challenging them to try a new one. Sometimes if a child is already eating, they only eat goldfish, right? I might even push them to a Cheez-It, which, in the beginning you'd go, well, why? Because that's almost the exact same thing. And I'm like, right, but it's also different, but it's close enough. And so you have to be able to, when you're looking at feeding therapy with these children, you have to be able to build their trust and build their understanding and expectation of what is going to happen. So you can't go with a child that's only eating goldfish and say, here's your piece of broccoli, because I can pretty much guarantee you that that child is not going to eat that piece of broccoli because it looks different, it smells different, it feels different. Like there's nothing that they can tie in that has any sort of similarity. And so if I can do some small steps to be able to fade that child into some more, challenging foods, right? We can look from going to a Cheez-It to maybe like a piece of toast with some melted cheese on it, right? So it still has that crunchy flavor, right? But it's leading us more to a cheese sandwich, which can then lead us to a turkey and cheese sandwich, right? And so it's one of those things that allows you that gradual introduction of some new foods to be able to work on that progress. My number one thing I focus on with feeding, though, is that idea of consumption. So any goal or anything that you're working on with your child when it comes to feeding is the idea that they're swallowing that bite of food. So you can change the texture to make it easier. You can change the bite size. You can change the utensil that you're using, change the actual food, the flavor of the food, but you want the access to the reinforcer to come from the actual consumption. A lot of times over the years, when I have families that come to seek my services, they're coming after having worked with another feeding professional that focuses much more on the engagement with the food. Have it be in front of you, touch it, squeeze it, lick it, kiss it, spit it out. And what they'll come to me and say is, it's really cool because my kiddo who never wanted to even hold a strawberry is holding a strawberry now. But we've hit a wall. I can't actually get them to take that bite of strawberry. And I say, right, because the reality is you weren't actually doing feeding therapy. You were doing more tactile type therapy, exposure therapy, things to be able to feel and experience those textures, get more comfortable with the item in front of you. But it doesn't matter whether or not it was food. It could have been any sort of item that the child, wasn't super comfortable with in the past. And so, when I look at the focus of goals of feeding therapy is that you're actually looking at swallowing that bite. Um, you can make adjustments to make that as easy as possible for the child to be able to access. You want to meet them where they're at, but you want that reward to come from the consumption of food.
So, even if a child is having a hard time with other areas, exposure, things like that, never to give the full reward reinforcer until they actually eat the food. Otherwise, the goal is just not aligned.
Well, right. So an example I share all the time is thinking about a raspberry, right? When I really like raspberries, I eat them all the time. But if I picked up a raspberry and I held it close to me and I looked at it and I squeezed it, and now I started to notice all the little hairs that wave in the wind off of the side of the raspberry, you notice that like there's a bunch of little bumps all around a raspberry, that maybe one side is a little squishier than another, one side, is juicier, and you start to squeeze it and now it's getting on your hand. That's not appealing to me. And so now the raspberries that I used to love to eat and actually enjoy, I'm now more turned off by the actual act of consuming them. And so I want people to think about that when they're exposing their children to foods in this way, is that if we hold it and we squish it and we, play with it and we feel, we're teaching that child to become more tolerant of the properties of that food, but we're not actually teaching them how to eat that food. And so I look at less is more. You do not need to inspect that bite. You do not want to overthink what's going on. You want to be able to pop that in, chew it and swallow it. And then again, depending on the age of the child, we may ask for some feedback. I want you to rate that food. For our younger kids, I just want you to get immediate access to some play and some toy time, because you did something that was hard and you're working through that. So when you're spending time engaging with the food, when it doesn't actually involve eating, you're more than likely going to hit walls when it comes to the actual consumption of the food, because we're actually, in most cases, making it more aversive.
It's so true. That is so true. That's a very, very, very good point. So I'm happy you brought that up. And I also want to talk a little bit about the independence aspect. I know you mentioned that could be an issue. I'm assuming that's if a child has a hard time eating on his own. What does that look like, and how do you deal with that?
Yeah. Well, so thinking back to some of those medical barriers, one of the first things that I would look at if a child's not feeding themselves is, do they lack the fine motor skills to be able to do that? Will it benefit them, if they don't already, to have an OT, working with them, or even within the BCBA in their ABA programming, to be able to work on how do we grasp that spoon or that fork, how do we scoop or stab, the eye-hand coordination that's involved from bringing the utensil from the plate up to their mouth. And so there's definitely activities that you can do as a therapist to be able to build up those skills if that's one of the areas of concern. You can do that outside of mealtime. So having them scoop, dried beans or something from one bowl and dump it into another bowl, or stab some Play-Doh with a play fork, right, and put it somewhere else. Be able to build up a lot of that strength. But oftentimes, even if it's not a fine motor issue, if you have somebody that's willing to feed you, why are you going to want to feed yourself? Because it's just so much easier to sit back and allow somebody to feed you. It's more effort, right? It's more response effort for that child to pick up the spoon or the fork themselves and take those bites. And so it's really about figuring out what is going to motivate that child to be able to put in that extra effort to feed themselves, so that you can fade out the parents or the therapist having to actually feed them. Because while fine motor can definitely play a role, it oftentimes is just, rooted in motivation. It's easier for them not to than to do it.
Very interesting. And I think the reason why you were talking about improving those skills outside food was that when it comes to food, the only reward you're giving is when they're eating it. So if they're having a hard time stabbing the food and they do it with the food and then they get the reinforcer, they're not going to be motivated to then eat the food because they already got the reinforcer. So focusing on those skills outside the food table, that's why you mentioned the outside, I'm assuming.
Absolutely. Yep. So you want to be able to build up those fine motor skills outside of the mealtime, so that when you're in the mealtime, you're focusing on the skill of taking the bite in the way that we want them to actually do it.
Amazing. Okay. Dena, you just gave like a wealth of information that I think could really make a difference to the BCBAs listening to this, how they approach the food and their clients and their families. So thank you for all that. Before we say goodbye, is there anything else any message you want to leave off with all the BCBAs before you go?
Yeah. Well, first of all, thank you, Penina, for having me today. I really love the opportunity to talk about feeding at any chance that I get. So I really appreciate being able to be here today to do that. I really think that, you allowed me to hit on a lot of these points today, where I really want BCBAs to take away that the food refusal shouldn't be scary. And there are definitely things that you can do as a BCBA to be able to help improve those eating skills of the children that you're working with. But also, if you're not seeing improvement, or you're not comfortable with even some of the things we talked about today, is that it is essential to be able to talk with the family, assess if it's a concern for them, and something that, they really should be reaching out and connecting with a person specifically focused on feeding to be able to address in an intensive treatment program.
Super important, yes. And Dena, if you could share your information with me so I could post it in the show notes so people could have access to reach out to you, that would be great. And thank you so much.